the Deputy Vice Chancellor Administration, Deputy Vice Chancellor Academic, Deputy Vice Chancellor Research, Innovation and Strategic Partnerships, the Registrar, the University Librarian, the Provost of the College of Medicine, Dean, Faculty of Public Health, Deans of other faculties, the Postgraduate School and of Students, the Rectors of Institutes and Centers, Heads of Departments, distinguished guests, ladies and gentlemen. The 411th in the series of the University of Ibadan Inaugural Lectures will this evening be delivered by the Dean of Public Health, Professor Olufunmilayo Fawole, of our Department of Epidemiology and Medical Statistics, on behalf of our faculty. Born in Ibadan on 11th March 1963, into the family of late Professor Eric Akiniyi Louis, an internal medicine physician, gastroenterologist, and late Mrs. Taiwo Lolade Erinade Louis Niteju Osho, a successful businesswoman. Professor Olufunmilayo Fawole, the second of 4 children, had a primary school education at the Mary Hill Convent School, Ibadan, from 1966 till 1973. She had her secondary education at the Queen's School, Ibadan, from 1974 to 1979, and proceeded to the International School, University of Ibadan, for A levels from 1979 to 1981. When I was the chairman of the board of governors of IS, I didn't realize that she was an old student. I would have gone to her cap in hand. I think Professor Adenito, DVC academic, should then consult her as early as tomorrow to start donating to her alma mater, as one of our most successful old girls from ISI. Later that year, that was in 1981, she was offered admission to study for the MBBS degree program of this university, which she completed in June 1987. She served as a house officer in the University College Hospital, Ibadan, from July 1987 and between July 1987 and June 1988. From August 1988 till February 1990, he served as a medical officer at St. Mary's Catholic Hospital, Ibadan, Railway Industrial Clinic, Enugu, Adefemi Hospital, Ikeja, Lagos, and Adeoyo Maternity Hospital, Ibadan. She was variously Senior House Officer, Registrar 2, Registrar 1, and Senior Registrar in the then Department of Preventive and Social Medicine from March 1990 till the 6th of June 1996. She took up appointment as lecturer grade 1 in the then Department of Preventive and Social Medicine of this university with effect from 7th June 1996. He was appointed honorary consultant to the University College Hospital, Ibadan with effect from 8th of June 2006. She was promoted to the grade of senior lecturer with effect from 1st October 1999, reader with effect from 1st October 2003, and she attained the ultimate accolade of professor with effect from 1st October 2009. Till date, Professor Fawole has over 120 publications in peer-reviewed journals, and she has supervised 145 master's degree dissertations, 2 PhD theses, and 8 fellows of the West African Postgraduate Medical College in Public Health. She is a fellow of both the National 1995 and the West African College of Physicians in Public Health 1996. She holds a certificate in clinical epidemiology from the University of Pretoria, South Africa, year 2008. She obtained a Master of Science degree in Epidemiology and Biostatistics from the University of Witwatersrand, Johannesburg, South Africa. Professor Fawole is a fellow has a fellowship in medical education from Pharma Institute in South Africa and case study development from Emory, Atlanta, Georgia, USA. Within this university, Professor Fawole has served in various capacities, including but not limited to being head Department of Epidemiology and Medical Statistics from 2014 till 2016, head of the Epidemiology unit for many years, acting head of the then Department of Epidemiology, Medical Statistics and Environmental Health, MSEF, from 2010 till 2012. Departmental representative on Faculty of Public Health Appointments and Promotions Committee, the member University of Ibadan University College Hospital Ethics Review Committee from 2007 till 2012. And from 1st August 2016, she has been the Dean of Public Health. And I hasten to add that her performance in office so far as the Dean has been outstanding. She is a recipient of several awards, including University of Ibadan Senate Research Grant, Witwatersrand Postgraduate Merit Scholarship, University of KwaZulu-Natal Research Award, UNIFEM UN Women British Council Department for International Development, that's DFID, World AIDS Foundation, Union for African Population Studies, International Agency for Research on Cancer, and WHO, HRP, TDR, and MIM. She provides technical expertise to the Federal Ministry of Health. She also serves as a consultant to the UN Women Health and Action Research Center, including the Nigerian Centers for Disease Control. Fawole is a member of several national and international organizations. He's a member of Nigerian Medical Association, member of the National Association of Public Health Physicians towards Unity for Health, and also member of the Association of School of Public Health and AFNET. Outside the University of Ibadan, Fawole worked with WHO as a National Surveillance Officer and State Coordinator for your state. She has served as Assistant Examiner to the Universities of Malawi and KwaZulu-Natal in South Africa, and also to both the West African and the National Postgraduate Medical Colleges in Public Health. Also External Examiner to Obafemi Awolowo University, Ilefe, and to the Lagos State University College of Medicine, Lagos, Ahmadu Bello University, Zaria, Olabisi Onabanjo University, Agoiwoye, Ladoke Akintola University of Technology, Osogbo, and Osun State University, Osogbo. She is married to Professor Adediran Olubukola Fawole of our Department of Obstetrics and Gynecology, and the marriage is blessed with children. I now call on Professor Olufunmilayo Fawole, our Dean of Public Health, to deliver our inaugural lecture on behalf of our faculty. The title of the lecture is The 5 W's, the Epidemiologist Quest. Professor Fawole.
Deputy Vice-Chancellor Administration, Deputy Vice-Chancellor Academics, Deputy Vice-Chancellor Research, Innovation and Strategic Partnership, the Registrar, Librarian, Provost of the College of Medicine, Dean of PG School, Dean of other faculties and of students, Directors of institutes, distinguished ladies and gentlemen. I consider it a great honor to deliver this year's inaugural lecture on behalf of the Faculty of Public Health. This lecture is the 8th from the faculty and the 3rd from the defunct Department of Epidemiology, Medical Statistics, and Environmental Health. I consider it a privilege and thank the Almighty because it is the first inaugural lecture from the new Department of Epidemiology and Medical Statistics. Coincidentally, I am the first woman to present an inaugural lecture from the faculty. At a time, I serve as the first female substantive dean. It is also from the first professor of human epidemiology so designated in the university. The first lecture from the Department of MSE was by Professor M.K.C. Schroeder of Environmental Health and was titled Waste, Wealth and Well-being. The second was by Professor E.A. Bangboye of Medical Statistics and was titled Medical Statistics, a Microscope for Health and Disease. Today's lecture is titled The 5 W's, the Epidemiologist Quest. It is the 411th lecture in the university and the 12th in the 2016-2017 series. Having opened the way for women, I can safely predict with 95% confidence interval that there will be more women from the department who will be presenting inaugurals in the not too distant future. When the opportunity arose to present this lecture, I accepted with a great sense of humility as I saw it as an opportunity to enlighten the university community and the public on what epidemiology is all about, and also to thank all those who have helped me in my academic journey. What is epidemiology? This is a question I'm frequently asked when I meet members of the public and they ask me what my profession is. The word epidemiology comes from the Greek words epi, meaning on or upon, demos, meaning people, and logos, meaning study of. In other words, it is the study of what befalls a population. It is best defined as the study of the distribution and determinants of health-related states or events in a specified population, and the application of this study to control the health problems. It relies on an unbiased approach to the collection, analysis, and interpretation of data. However, epidemiology draws on methods from other scientific fields, including biostatistics and informatics, biologic and economic, and social and behavioral sciences. A good news story or gist must include the 5 W's for the story to be complete. The same is true in characterizing epidemiologic events. Whether it is an outbreak of Lassa fever or the use of pap smear tests to detect early cervical cancer. However, most epidemiologists tend to use the synonyms 5 W's and match the why and how, while a few use the synonym 5 W's and 1 H. The 5 W's. What is the diagnosis or the health event? Who refers to the persons concerned? Where is the place? When? Time. Why or how refers to the causes, risk factors, and modes of transmission. Quest is a search or pursuit made in order to obtain something. It is a difficult journey towards a goal. Our goal in epidemiology is to understand and explain the occurrence of health events. However, even after undertaking this quest, I have tried to go a step further and take action to address gaps. Epidemiology is concerned with the frequency and patterns of health events in a population. Frequency refers to the number of health events, such as the number of cases of malaria, meningitis. Patterns refers to the occurrence of health-related events by time, place, and person. Time patterns may be annual, seasonal, weekly. Place includes geographical variation. Person characteristics includes factors such as age, sex, and socioeconomic status. Characterizing health events by time, place, and person are activities of descriptive epidemiology. Epidemiology is also used to search for determinants, which are the causes and factors that influence the occurrence of diseases. Epidemiologists assume that illnesses occur only when the right accumulation of risk factors exist in an individual. To search for these determinants, we use analytical epidemiology, which provide information on the why and the how. Hence, case control, cohort, experimental studies, including systematic reviews, are conducted. Epidemiology was originally focused exclusively on epidemics of communicable diseases, but was subsequently expanded to address non-communicable diseases. By the middle of the 20th century, epidemiological methods were applied to maternal and child health, occupational health, and environmental health. Indeed, the term health-related events can be seen as anything that affects the well-being of a population. Nonetheless, many epidemiologists still use the term disease as a shorthand for a wide range of health events. Major areas of epidemiological study include disease etiology, surveillance, study designs, screening, and clinical trials. At this juncture, I would like to encourage anyone who may be interested to come and enroll for one of our training programs. Currently in the department, 3 subspecialties of epidemiology have emerged: basic, field, and clinical epidemiology. Social is work in progress. Mr. Vice Chancellor, sir, distinguished ladies and gentlemen, I will be presenting to you today some of my contributions in the field of epidemiology. This has been in 3 main areas, namely research, training, and providing community service. I shall be starting off with my research engagements. My research engagement lies in 3 areas, namely malaria, STI, HIV and AIDS, and gender-based violence. Malaria. My interest in malaria was triggered by the fact that I rarely have the condition, despite the endemicity of the disease. Since adulthood, my episodes of the infection are so widely spaced, occurring every 6 to 8 years. This prompted me early in my career to take an interest in the disease. Therefore, I conducted my Part 2 dissertation for the West African College on malaria. On our appointment as a lecturer, I went to PIMRAT to inquire about this unique phenomenon. Although I never got to investigate why, being a public health physician, however, this led me into close contact with the then director, Professor A.M.J. Oduola, and more enthusiasm for malaria research. Malaria is a mosquito-borne infection. It is a leading cause of death and disease in many countries in sub-Saharan Africa, where young children and young pregnant women are the groups majorly affected. Nigeria has the greatest disease burden among countries in the world. About half of the population will have at least one attack in a year. Mr. Vice Chancellor, sir, my first few studies on malaria sought to describe the case management of this highly endemic disease. Our study of the case management practices of caregivers of children under 5 years of age found self-medication with orthodox drugs to be the common practice. Paracetamol was a common drug used by caregivers, while a few used anti-malarials. However, dosages were often incorrect. As shown above, the health facility was where mothers went first to seek care for fever. However, most went on the 3rd day after fever started. This was reported in our publication, Fawole and Onodeko, 2001, Fawole, Onodeko and Oijide, 2003. I was co-investigator and epidemiologist in the malaria research group that implemented 2 WHO TDR MIM African Research Strengthening Grants. Professor Adeniyi of blessed memory led the research team of the project that improved home management of malaria in children, while Professor Ajayi Oba led the second theme on phytomedicine compendium for Nigeria. These 2 projects gave me another opportunity to address the 5 Ws of malaria infection in Nigeria. HMM was an implementation research. Firstly, we studied the knowledge and case management practices of mothers of children in 2 urban and 2 rural LGAs of Oyo State. We found that for many, knowledge was inadequate and treatment practices incorrect. Also, traditional healers were patronized but were unskilled to manage children. Fawole et al., 2009. Hence, we sensitized mothers and traditional healers, trained health workers and patent medicine sellers, paid advocacy visits to state and local government executives. Also, we distributed posters in the state. Subsequently, we found a significant improvement in treatment practices, patient referral, presentation of children at the health facilities. Thus, we succeeded in reducing childhood morbidity in these LGAs. Phyto was a national study which aimed to know what herbal remedies were used to treat malaria in urban and rural communities in southwest, north central, and south-south zones of Nigeria, with a view of identifying new potent antimalarials. On completion of the study, we identified 112 herbal remedies and 25 recipes. Further studies confirmed the efficacy of 2 out of the 8 most recommended remedies. Another positive outcome of these 2 studies was that we built the capacities of researchers in 2 universities, the Obafemi Awolowo and the University of Port Harcourt, on malaria research. In turn, our capacity, UI, was built by 2 northern partners, the CDC Atlanta and the King's College London. These studies were followed by other studies shown above. However, notable was the research prioritization workshop, which aimed to assist postgraduate students develop relevant malaria research proposals. This was during my sabbatical leave with the African Field Epidemiology Network in Abuja. The workshop A was based on the premise that although several research groups have done extensive work on malaria, the link between the research community and policy formulation has been suboptimal. Technical papers were presented by 10 experts from different backgrounds. As shown above, The areas of strongest need for research identified by the students in the training need assessment was on malaria prevention. On completion, a compendium that addresses the research needs of the country was published to guide students in training institutions in Nigeria on their choice of research projects. This is Fawole et al., 2014. STIs and from STIs to HIV. In my quest to measure the 5 Ws of another common but hidden public health problem, after I was employed, I took interest in research on sexually transmitted infections based on my previous work at the Special Treatment Clinic. I used epidemiological tools and methods to identify the why for the decline in patient clinic attendance after measuring trends in attendance over a 20-year period. Introduction of fees, social strife, perceived reduction in quality of service were reasons identified to be responsible for the decline. The public health implications of the decline is an increased risk of HIV transmission due to inadequate treatment provided by alternative providers who are often unskilled. Fawole and Asuzu, 1997. To understand the who, a 5-year review of patients seen at the clinic was undertaken. We found adolescents constituted 38% of attendees. As regards the what, 1 in 5 youth had gonorrhea. As for the who, most of the adolescents were students and females. Hence, we recommended school-based education programs to help adolescents avoid these infections. Fawole et al., 1999A. In a bid to prevent HIV infection, one of its risk factors was studied among the clinic attendees, genital ulcer disease. Genital ulcer disease constituted 10% of all STI managed, which is a tip of the iceberg. Who? Its prevalence was highest in the 20 to 29 age group. Most of the patients were unmarried and were students. Why? Risk factors were having multiple sexual partners and unprotected casual sex. These and other findings in the clinic led to my subsequent studies on HIV prevention among the youths. Fawole and Asuzu, 1997, Fawole et al., 2000. My contribution to the body of knowledge on HIV and AIDS prevention included surveys and intervention studies with young people. With funding support from the UI Senate Research Grant, UNIFEM, DFID British Council, we implemented interventions for adolescents. Generally, we found that knowledge of sexual transmission of HIV and AIDS was good, but the proportion aware of other modes of transmission was much lower. We also found that about a third were sexually active, of which about a quarter had multiple partners. Fawole et al., 1999B. The sexual practice of out-of-school youths was more alarming. When we compared 3 groups of young people, apprentices, traders, and students, we found the sexual behavior of the apprentices to be the most risky. Amoran Fawole, 2008. Therefore, we decided to work with out-of-school youths. We compared 2 groups of apprentices, those in organized apprenticeship program with a highly mobile unaffiliated group of apprentices. We found the unaffiliated group engaged in risky HIV-related behaviors, and this was reported Abdurrahim and Fawole, 2009. With these dismal results, there was an urgent need to identify stakeholders who could influence the knowledge and practices of young people. Hence, studies with peers, teachers, parents, and religious leaders were implemented as above. Also, my research directed attention on the young people too, and assessed the effects of the television and the internet on their behaviors. How? We found that 14% of the students go online to watch sexually explicit movies, and 1 in 4 experience sexual solicitation online. Many admitted they were influenced after watching these programs. Salawu and Fawole, 2015. Who? Boys were approximately 5 times more likely than girls to watch such movies and experience solicitation. The effects of the electronic media on young people prompted me later on into another research on the effects of the social media, which is reported as Makinde and Fawole et al., 2016. Based on these results, we implemented interventions to address these risky behaviors. The intervention succeeded in changing young people's behavior by encouraging them to abstain, adopt sexual practices, and empower them by providing factual information. Fawole et al., 1999C, 2003, 2005B, Fawole and Ashekun, 2005, Adunwa and Fawole, 2008. Also, practical and feasible HIV training programs, which can be replicated in other schools, was developed and published. Fawole et al., 1999C. From HIV to gender-based violence. My experience working on HIV among the youth led to my great passion for research on gender-based violence, which we found was a major problem young women experience. Simply put, gender-based violence is acts that inflict physical, mental, and sexual harm or suffering, threats of such acts, coercion, and other deprivation of liberty. It occurs in every culture and social group. Most are directed against women, hence the term violence against women. As regards prevalence in Nigeria, the 2013 Demographic and Health Survey reported that 1 in 4 of married women had at least once experienced intimate partner violence, and 19% had done so in the last 12 months. My research in this new field has sought to describe the epidemiology of gender-based violence and provide data on the 5 Ws of different study populations in Nigeria. As regards the WHO, as shown above, we studied in and out of school youths and women and have 15 publications on these groups. We also studied other groups such as men and boys, parents, healthcare providers, law enforcement officers, media practitioners, and even medical students. And we have over 50 publications on violence against women. Hence, I have severally been acknowledged as one of the leading researchers on this topic in Nigeria. One of the highlights of my work on gender-based violence is that I succeeded in highlighting and brought to the fore economic abuse as a common form of violence women experience, Fawole, 2008. Hitherto, only 3 types of violence were researched. Now, other researchers have begun to work on this form of abuse. Also, the areas further research are required were identified for gender-based violence researchers in Nigeria to address. This was published as chapters in 2 books. These books are used as advocacy tools by women groups and guide interventions by program managers and researchers to improve Nigerian women's health and status. Some of the results of these studies are shown in the figures and tables above. It is interesting to note that many women felt beating was acceptable if a wife disrespected her husband, although the men did not agree. As regards the 5 Ws of gender-based violence, most of our studies reported emotional violence, such as verbal abuse and controlling behaviors, to be the commonest form of violence women experience. Fawole et al., 2002, 2005A, 2008, Balogun and Fawole 2012, Adejime and Fawole 2015. We found that both sexes were victims, but male against female violence was far more common. All ages experienced violence, Fawole et al., 2002. However, adolescents and young women were more vulnerable. Where? The family was the primary site of violence. The society also justified the behaviors of male abusers and supported harmful traditional practices. Why? Reason is the power inequality between women and men, but other contributing factors we found included harmful alcohol use, children who witnessed parental violence, acceptance of violence as the norm in a relationship, having multiple partners, low status of women in the society, social norms supportive of violence. Examples of these norms were that a man has a right to physically discipline a woman for incorrect behavior, beating is an acceptable way to resolve conflict in a relationship, and sexual coercion is a mark of masculinity. Fawole, 2014. The health consequences of violence can be fatal and non-fatal. Fatal includes suicide and homicide, some of which have been in the news in recent times. Non-fatal consequences include poor health, depression, HIV and unwanted pregnancies. We found that women who experienced violence were more likely to have obstetric problems than those who did not. Therefore, we studied final year medical students to determine how skilled they were to detect and manage victims in the future. About one half admitted they could detect a victim. Based on our findings, we sought to apply the public health approach to prevent violence. This approach considers violence as the outcome of multiple risk factors. Therefore, we conducted intervention studies and worked with different stakeholders. We dialogued and trained drivers, instructors, journalists, police and legal officers. After these interventions, there was significant improvement in knowledge, better appreciation of vulnerability to violence, and more victims sought help following violent acts. Fawole et al., 2003, 2005, 2005B, 2013, 2013B, Adjunct 2011. The table above shows our funded intervention studies and publications on gender-based violence. My experience in researching violence and HIV prevention among youths was summarized in a paper that highlighted the lessons learned from these interventions. Fawole et al., 2004. Some of the educational materials we developed are highlighted in the figures above. The take-home message is, there is no excuse for abuse. Let us stop violence against women now. Our studies were not limited to women. We also studied men and children. We dispelled the myth that men do not experience sexual violence from women and found that about one half had experienced some form of sexual harassment from women. We worked on child sexual abuse and looked into after-school care of children, a period they may be vulnerable to abuse. Many were either left alone or with relatives. There is no excuse for child sexual abuse, and we all need to say no to child abuse. Outbreak investigations. Despite the fact that epidemiology has expanded beyond early definitions as being the study of epidemics, investigating outbreaks still constitutes an important epidemiologic activity, as sadly enough, epidemics continue to occur. I have promoted public health by investigating and controlling epidemics, otherwise known as outbreaks. First, the cholera outbreak in Oyo State. One of the first epidemics I took part in this investigation was an outbreak of cholera in Kusa, a mining community in Itesiwaju, LGA. It is located about 350 kilometers north of Ibadan and is a very hard-to-reach area. The inhabitants are mostly immigrant and illegal small-scale miners who mine for tantalite and sapphire. About 100 deaths were reported over a 2-week period to the state, hence investigations was commenced. There were two interesting lessons learned after the investigation. Firstly, despite the severity of illnesses, families denied they had ill persons and healed cases out of fear of forceful evacuation from the mines. Secondly, the local health authorities avoided response, stating it would be wasteful spending resources on immigrants. One of the executives stated, "They are not part of us. They are from Dahomey. Why should we waste our money treating them? Leave them to die." However, after several advocacy visits and education of the executives on the risk of spread to the general public, including to themselves, they provided the resources to contain the outbreak. Fawole and Kolude, 2003. Cholera in Ogun State. Another cholera investigation, an outbreak I contributed to its control was in Abeokuta, Ogun State in 2013. 37 cases and 5 deaths were reported to the state from the 4 LGAs of Abeokuta Metropolis. Therefore, a case control study was instituted. The protective factors identified after investigations were hand washing with soap and water before eating, while the risk factors were drinking sachet water or contact with a diarrheal case. This outbreak was caused by consumption of certain brands of sachet water due to disruption of water supply within the city due to road expansion works. There was a high demand for this bagged water, hence quality was not maintained in its production. Environmental hygiene and poor personal hygiene by contacts promoted person-to-person transmission. We carried out intensive health education, emphasizing the importance of hand washing with soap. Based on our recommendations, sanitary inspection of sachet-producing factories was done by the state. Thus, our interventions succeeded in reducing illnesses and deaths, and thereby saved lives. Ayeloto and Fawole et al., 2013. Lead poisoning. I documented the series of lead poisoning outbreaks linked to artisanal gold processing that killed at least 400 young children in Zamfara and Niger states. After investigation, two main lessons were learned. First was the need to maintain an alternative source of livelihood for the poor agrarian communities with the ban by the government on mining activities. Secondly was the rebound effect of the sudden application of stringent control measures without keeping in mind the risk of more underground mining, hence the spread to Niger State. We carried out intensive health education to protect children in particular and supported the state with the introduction of new income-generating activities in these communities. 4, Ebola virus disease. Mr. Vice Chancellor, sir, I contributed to the certification of Nigeria as being Ebola-free. This was a feat. This was a feat that received international acclaim because of the rapid response by the Nigerian government and its partners. We can still recall the story of the ill traveler from Liberia to Lagos who was confirmed to have Ebola after being admitted to a private hospital in July 2014. After completing the investigations, 19 laboratory confirmed and 1 probable Ebola case and 899 contacts were identified. The epidemiological investigations. We carried out outbreak investigations in 3 cities, Lagos, Port Harcourt, and Enugu, Fawole et al., 2016b. We traced contacts, managed alerts and rumors, and implemented community surveillance. The results of our activities and the number of cases and contacts from the 3 sites is shown in the table above. Of the 20 cases, more were females and healthcare providers. 8 cases died. Of the 899 contacts, females were also more because of their caregiving roles. Most of the cases and contacts were in their productive years. We also provided technical support to contact tracers and mediated for contacts who experience challenges while at their work. Mr. Vice Chancellor, sir, training. I am happy to report, sir, that we are blazing the trail of epidemiology training in Nigeria. The University of Ibadan is the first institution in Nigeria to establish a postgraduate epidemiology training curriculum. We developed and commenced postgraduate training in the programs above: MSc Epid, MPH Field Epid, MSc Clinical Epid, to mention a few. This was later adopted by other tertiary institutions in the country, including the universities of Lagos, Ilorin, Uyo, ABU. I'm happy to state that based on the legacies of my teacher in the discipline, namely Professors Oyediran, Oyejide, and Professor Kale, we are blazing the trail of epidemiology training in Nigeria. As one of the pioneer members of EMSE, Dr. Lola Dare and I developed and established the curriculum for undergraduate and postgraduate training under the headship of Professor Bangui. Later, as acting head of department and in conjunction with my colleagues, Dr. Fatiregun, Dairo, Ajayi, Adeoye, and Adedokun, I spearheaded the development and approval of the MSc Clinical Epidemiology. I initiated the first curriculum review of academic programs in the department in November 2011 in conjunction with colleagues. Currently, we are now 8 epidemiologists in the department, from the initial 6 2 decades ago. We have had an increase in both the number of our programs and student admission, but have not had a proportionate increase in epidemiologist lecturers. The Nigerian Field Epidemiology Training Program. Prior to the establishment of the MPH in Field Epidemiology Practice, I paid advocacy visits to the Federal Ministry of Health, Abuja, to ensure that the field epidemiology training is domiciled in our department. The MPhilTip is a 2-year full-time training and service program. Nigeria is one of the 16 other African countries who are part of the AFINET network. Incidentally, today is the United Nations declared Africa Day. And I'm happy to note that Nigeria is in the lead in Africa and is looked up to and emulated by other African PhilTips. We train epidemiologists in 3 tracks: medical, laboratory, and veterinary practice. Mr. Vice Chancellor, sir. Also, Nigeria is among the first countries to implement the veterinary track to address the ever-increasing threat of zoonotic infectious disease and strengthen the collaboration between human, animal, and environmental health sectors, thus promoting the One Health concept. Unlike many training programs, PhilTip is fundamentally field-based, hence the term shoe leather epidemiology, indicating the walking the training entails. This program is under the auspices of the Federal Ministry of Health and Agric and Rural Development and is implemented in conjunction with ABU Zaria. It is supported by the US CDC, PEPFAR, PMI, and other partners. The program was established in the department through the efforts of Professor Bangboye Oke, Drs. Ajayi, Adekunle Fatiregun, and Dr. Dairo. Dr. Ajayi and I supported the program when there were teaching problems and saved it from a premature death. Mr. Vice Chancellor, sir. During my sabbatical leave, I worked as an academic coordinator with the PhilTip program, and on my return, served as the university focal person. During this period, I strengthened the standing of our department on the program and ensured that only the very best applicants were admitted into our dear university. Also, our admissions have continued to increase over the years. The summary of our admissions are shown above. Our students participated in the Ebola investigations in Nigeria, Sierra Leone, and Liberia, Olufunmilayo and Fawole et al., 2016. Our mentees have evaluated disease surveillance systems, assessed immunization coverage, and conducted population surveys. They have trained health workers. Hence, together, we have been able to impact positively on the health of Nigerians and the West African subcontinent. Nigeria's response to the Ebola outbreak experience was so commendable that I was requested to document it as a case study for epidemiology training in Africa. This was done in conjunction with faculty from Emory University, Atlanta. Mr. Vice Chancellor, sir, I wish to end this section by seizing this opportunity to humbly reiterate our request for more staff to meet the training demands of our department to enable us to continue to blaze the trail of epidemiology training in Nigeria. Mentorship of students and staff. Mr. Vice Chancellor, sir, together with others, I have contributed to the provision of competent human resource in several public health institutions by mentoring students who have taken up positions at various institutions at home and overseas. Till date, I have supervised to completion 145 postgraduate students and taught 20 sets of medical students. We have built the capacity of our students who have done the university proud by receiving acclaim at national and international conferences. The graduates of our programs now work at international organizations, AFINET, WHO, UNICEF, to mention a few. At the federal, state, and local government, where they serve as directors, program officers, state epidemiologists, and PhD coordinators. 3, in the university and in the hospital, our mentees include medical consultants and resident doctors. This included current and past heads of departments, ex-deans, current deans, and professors. Our students are also in the diaspora and can be found in the West African subcontinent, the US, the UK, and in Canada. My prayer, sir, is for our students to be successful epidemiologists, greater than us, do the nation proud, and most importantly, serve humanity. Amen. Community service. the Aladura Rural Outreach Clinic. The clinic is a brainchild of Dr. Olajide Ijaola, a physician based in the UK, who requested that I establish the clinic in Nigeria. The village is a border community located between Oyo and Ogun States. It was officially commissioned by Dr. Lola Adekunle, the then head of department. The facility provides outpatient care and outreaches to a cluster of 13 villages. A 7-seater Nissan bus donated by the foundation conveys the medical team to the clinic. The family was so impressed with activities of the department such that 8 years later, they again donated an Opel Meriva car for commuting to these villages. Polio Eradication Initiative. I contributed to the progress the global community and Nigeria made towards polio eradication. As recently as 2012, Nigeria accounted for more than half of all polio cases worldwide. On the 25th of September 2015, WHO Geneva announced that polio was no longer endemic in Nigeria. This was after 25 years of concerted effort by all levels of government, international organizations, and other partners. However, on 1st of August 2016, the government reported the deeply saddening news that 2 children had been paralyzed by the disease in northern Borno State. Mr. Vice Chancellor, sir, some of the polio eradication activities and progress in Nigeria during the period I was consultant with the WHO are above. These activities were done in conjunction with the WHO team comprising of Drs. Kolide, Leo Ugegele, and Pelumi Adesoya. First, routine immunization. We facilitated the uptake of all the vaccine-preventable diseases for children in the state. 2, the National Immunization Days. We provided technical guidance for the planning, implementing, and the reporting of supplemental immunization activities, commonly known as NIDs. To achieve this, we made repeated visits to different communities in the 33 local government state areas of the state. Distant LGAs, the Fulani girls, were visited regularly and severally by us. Also, communities at international boundaries were visited in a bid to reach every child. Also, I was enlisted to support the NIDs in Kebbi and Jigawa states during the period when there was refusal of the OPV in the northern parts of Nigeria, and worked severally in Akwa Ibom State. 3, surveillance. We conducted active search for cases of acute flaccid paralysis in health facilities and communities. Our surveillance results guided immunization activities and national policies on polio eradication. These activities enabled me to contribute to strengthening the surveillance system of the country. 4, mop-ups. We detected wild polio in the state in 1999, 2003, and 2004. Therefore, it was imperative we mopped up these areas. We found incomplete immunization and poor environmental sanitation as important factors contributing to the occurrence of the virus, and address these gaps by educating caregivers and community members. In conclusion, sir, this lecture has highlighted some of my contributions using the 5 W's. The use of epidemiological methods has guided national policy, program management, disease control, research, service provision, and training. Epidemiology has enabled me to contribute to public health in Nigeria and abroad. I will continue to contribute my quota to this discipline so that the next generation of epidemiologists can still be guided by the 5 W's. Who, where, when, what, and why. For the control of public health events, for these are the epidemiologist's quest. My recommendations, Mr. Vice Chancellor, sir, to promote interdisciplinary research and collaborations across departments, disciplines, and sectors. Research that includes epidemiologists, among other experts, are more likely to obtain funding and be accepted by high-impact journals. 2, as the leading epidemiology program in Nigeria's training institutions, we need to train more epidemiologists for the country to enhance quantification of health events. I use this opportunity to reiterate our humble request for more epidemiologists in my department. Sir, we need more staff. 3, more community-based studies and implementation researches are required to improve public health. Community-oriented projects have the advantage of improving the health of large numbers of persons, and changes are almost instantaneous too. 4, using epidemiological methods. Research into more contemporary health events, of which we know little about, are urgently required. Such events include migrant health, substance abuse, alcohol abuse, gun violence, even social ills like community violence, insurgency, religious fundamentalism, Boko Haram, suicidal tendencies, and kidnapping, to mention a few. Mr. Vice Chancellor, sir, despite these challenges, we shall achieve our goals to get to our final destination, which is to prevent and control diseases in Nigeria. Acknowledgements. Mr. Vice Chancellor, sir, I cannot conclude this lecture without expressing my gratitude to the Almighty and also to other persons who helped me to get to where I am today. My greatest gratitude is to the Creator of all, firstly for life, and then for all the opportunities that have come my way professionally and otherwise. I remain eternally thankful. I wish to thank my parents, both of blessed memory, Professor Eric Akiniyi Lewis, an internal medicine physician, gastroenterologist, who believed I could study medicine when I lacked confidence in myself, then as a young secondary school student. Unfortunately, he never lived long enough to know I was admitted into medical school. I also thank my mother, Mrs. Taiwo Lewis, ni Teddy Osho, who was left alone with our upbringing with the early demise of my father. Her support and care enabled us to get to where we are now. Next, I thank my brothers and sisters, my older sister, Folashade Omobolad, my brother, Olumide Lewis, my younger sister, Tolulope Lewis, Tamoka. They all supported me throughout my academic pursuits and watched out for my progress, since none of them reside in the country. I also thank my in-laws, especially my brother-in-laws from the Fawole and Lewis families, for the peace and love they extend to me. I'm grateful to my supervisors, Professors Odunton, Onodeko, Oyejide, and Asuzu. I thank Mr. Lawani for employing me as a lecturer. I thank Professor Bangboye for giving me the enable environment to thrive in the early stages of my career. I also thank my teachers in epidemiology, Professors Oyediro, Kale, and Oyejide. Sirs, your retirement left a big vacuum in epidemiology units. As a young lecturer, I had to forge ahead alone, but was later joined by another capable lecturer, and after some years, and he was able to uphold the department. I am most indebted to Professor Emeritus, Professor Olufunmilayo, who helped me when the need was greatest. Thank you, sir. I thank my teachers at primary and secondary school, up Mary Hill, up Queen School Ibadan, pass on the torch, up ISI. I thank my teachers and the College of Medicine, Great UI, and in UCH, the University of Witwatersrand, Johannesburg, the South African FIMA, the University of KwaZulu-Natal, Durban, and Emory, Atlanta. I thank my students in giving. The greater recipient was me. I thank my research collaborators from the Faculty of Public Health, especially Professor Ajunwa and Dr. Oshumbade, the London School of Hygiene and Tropical Medicine, and the Malaria Research Group. I acknowledge the funding support from the following organizations above. I thank the Vice Chancellor, Professor Idowu Olayinka, for his concern and support over the years, particularly in 2012. I acknowledge all the principal officers of the university, especially my fellow deans. I thank the past and present administration of the UCH, the college, particularly the provost, who incidentally was my classmate in ISI and in medical school. I thank both academic and non-teaching staff of EMS department and all staff of the faculty, my colleagues and friends at WHO, AFINET, and MFLT offices are also acknowledged. I thank all adherents of the Grow message at the Grow Center in Ibadan and the Grow Movement Nigeria, particularly Dr. and Mrs. Fatokun and Dr. and Mrs. Olutogun. I acknowledge the help from Ife Awoyelu, Mrs. Fadei, Dr. Zadeboale, Dr. Sheung Akinyemi, Dr. Fati Regun in the review of this manuscript. Professor Fashola, Professor Fawole, and Professor Akonde all read this and reviewed these manuscripts that I'm presenting. The help from Mr. Adroja, Dr. Oluwatosin, Drs. Balogun, Osifo, Olawoye, in the preparation of this presentation is also acknowledged. I acknowledge members of the EMS and EHS department who helped me review the presentations. I thank our sons, Ayoda Mokwe and Bolutife, for their understanding and support of me over the years. But not in the least, I thank my husband, Olubukola Adeniran Fawole. He is the love of my life. He is my role model. And he was and still is my heavenly sent support. You have been a pillar of strength for me throughout my academic journey, right from when I started the residency training program. First with the decision to specialize in community medicine, then with the strong support during my Part 1 and Part 2 examinations, to the even greater support after my appointment as a lecturer. You read my first 40 or so papers before I submitted for publication to ensure that they were accepted. There was never a complaint about the many trips being a field epidemiologist entailed, including being away from home for training abroad and on sabbatical leave twice. I started lecturing earlier and therefore was ahead. However, this was never an issue. Your concern was for me to be happy and successful. I thank you immensely for this. May the good Lord bless our home. Amen. Mr. Vice Chancellor, sir, ladies and gentlemen, I thank you all for your kind attention. By His grace, your own day of success will also come and meet us in good health. Then we shall have cause to listen to the 5 W's of your experiences. May the good Lord grant it. Thank you one and all.